EBV lymphoproliferative disorders that you see following a marrow transplant or a cord blood transplant are these very rapidly aggressive tumors that are usually clonal B-cell lymphomas that emerge early after the transplant and largely reflect the fact that the transplant recipient is very, very heavily immunosuppressed. So in a normal unmodified marrow transplant, they can be 1 to 3%. If you take the T cells out of the graft, it can be 5 to 7%, or if you have naive T cells like a cord blood transplant, it's about 3.5% of the cases can develop this. And what happens is you develop fever, usually with lymph nodes that are enlarged. You can have disease that affects more often than not the pharynx, and they get sore throat or things, but they have massive nodes, or they have them in the intestinal tract or even the brain. And the limitation is that they are very aggressive, and untreated, they have a very, very short lifespan. It's been measured as under a month.
What has been done for EBV lymphoproliferative disorder in the past?
In the past several years, the groups have used Rituxan, which is an antibody directed against B cells, and about 50% of the patients will respond to that, but those responses will be sustained in only about 50% of the individuals. That is for patients who have overt disease. And so what we had done back in 1995 is to show that you could use T cells to deal with these using T cells derived from the transplant donor. And our group, the Baylor group, and other groups have done a lot of work using immunized T cells grown in the test tube derived from the transplant donor to treat these. And as it's turned out, it takes very, very few cells to do it, but they are able to induce durable remission. So that's the new part.
Now, what has been the problem in the past? Speed is an issue, isn't it?
That's right. The making of the cells takes at least 60 days. More often it takes longer than that. And so what we've done is to develop a large bank of these cells. These are all ready for adoptive therapy. They're all HLA typed, so they're ready to go. And we also have defined the HLA restriction of the T cells. T cells see a virus peptide in the context of an HLA molecule. And because we've been able to identify this restriction, we can pick cells that should be able to kill the patient's tumor.
Can you tell me what you did in the study?
We studied a series of patients, 26 patients who received EBV-specific T cells from their transplant donor, and another 31 patients who received T cells from a third-party donor chosen from the bank. And we were looking in the third-party group in particular at patients who had failed Rituxan. And what we did was to give infusions of these T cells once a week for 3 weeks. We would wait then 3 weeks. We would potentially give second cycle depending upon their response. What we found in this circumstance was that over 60% of the patients were able to achieve a CR or a very durable PR, of the disease. And in the third-party cases, in the first study where we're using 1 million per kilogram dosing, it's about 50% of these patients are doing perfectly well at a year, and in the second study it's 72%. And the important point there is these patients who do respond with a complete remission or a partial remission do not recur with EBV.
And basically you have an off-the-shelf agent to use.
That's right. So ultimately what we're hoping, right now patients come to us to get this treatment, but our ultimate hope would be that a center that's doing these kinds of analyses could send the HLA typing and the pathology, and we could send cells back by return mail.
So what should cancer doctors think about all of this, and what should they do for their patients? I mean, at the moment they just have to get in touch with you?
Correct. And if they do so, we have a very rapid search system. And as I said, a very large proportion of individuals, almost 98.6% of the searches that we've requested, we've been able to find a transplant appropriate T cell for the treatment of these disorders.
Now, if this is scaled up and this agent, this class of agent becomes widely available, could you eliminate the threat of EBV, lymphoproliferative disorder, do you think?
You potentially could, and early on, there's Dr. Rooney at Baylor who actually had used these as a preventative, as a prophylaxis, and had treated a large number of patients who never developed EBV. The limitation you have with some of these viruses like EBV or CMV is you have to be sure that the T cells that are infused see the virus. So ultimately, the issue will be treating patients who show evidence of the virus. At that time, their T cells can see the virus and they really do their job. Prevention clearly for EBV is possible, and for some of the other viruses, it's likely going to be very, very early therapy. It'll eliminate a lot of the complications that we have.
And what about the mutations happening within EBV? Is that a threat?
It is an issue, and one of the reasons why we think this bank is so useful, because EBV does have a tendency to have multiple mutations. There are multiple different strains of EBV, and in some instances, those mutations affect the peptides that a T cell would see. And what we're able to do in this setting is to choose T cells that are reactive against a different peptide presented by a different HLA and get around that. And we found this to be effective in 5 of the first 7 patients we've used this approach on.